kind of work. Bevan works to highlight national best practices in the field, support skill sharing across platforms, and amplify the impact of clinical outreach education. And our apologies, since we don't have your image on the presentation, Anna, but we also are being joined today by Anna Morgan, who is a program manager at NaRCAD. Anna joined the NaRCAD team in the fall of 2019, coming on board to manage a portfolio of academic detailing programs, manage events, and strengthen NaRCAD's national reach through research, on-site training, and training facilitation. And I have to say, having seen all three of you present about academic detailing in the past, I'm very grateful that y'all are here. Y'all make it a very engaging experience. You know, just going into this session, I always think about something that I learned from y'all, right? Which is how 90% of the world's data, right, was made in the last 2 years. So how do we expect our clinical and clinicians to navigate all of this? So I'm excited to hear and learn from y'all today, and I'll turn the floor over to y'all.
Thank you so much, Jose. That might be the nicest and most enthusiastic introduction that we've ever been privileged to receive. So thank you for hosting us, and my colleagues Mike and Anna and I are all very excited to be here. So thank you so much for the invitation. So kicking off, we always like to talk about our sources of support, so it's very clear where we get our funding from. I won't belabor it, but you can take a quick scan, and we're happy to make this information available to you if you have any questions. But the core of our funding comes from the Agency for Healthcare Research and Quality, AHRQ, as well as PCORI and the CDC, and we work directly with public health, both local and state programs. So we're very excited to be expanding more and more into public health, and to say that we are building a really lovely relationship with LACOA and their partners. All right, so you've already gotten a wonderful introduction to us and our colleague Anna. So here we are, you can see us from our news anchor-esque backgrounds and pick us out. I'll just turn it over to Anna to say a quick hi, and then Mike to say a quick hi so you know our voices.
Good morning, everyone. We're so happy to have you all here today. My name is Anna Morgan, and as I was introduced so beautifully, I am the program manager at NaRCAD.
Great, and over to Mike.
Good morning, everyone. Thank you for joining. I'm Mike Fisher, and I'm really excited to have a chance to spend some time with you this morning and hopefully to learn from each other.
Absolutely. All right. So here are our goals for the day, and I'm sure things beyond these goals will be touched upon. And we're excited to learn what your goals are as well. So we obviously want to teach you a little bit more about AD. And for those of you who have been with us before, it'll be a quick refresher. We want to focus in on the ways in which AD has been a wonderful strategy to improve outcomes related to HIV prevention and treatment by supporting those frontline clinicians who want to help their at-risk and their patients who really need that kind of ongoing care. We want to talk a bit about how academic detailing really works best when it's paired with other community-wide interventions. And again, our partnership with LACOA has really allowed us to think more broadly about how partnering with other organizations who are so well connected to their respective communities is the best way to make outcomes better for patients, but also to do so in a sustainable way where clinicians feel very supported and able to rely on a long-term relationship with their academic detailer. We'll talk a bit more about that in a moment. We'll discuss a bit about how, as academic detailers work to empower clinicians to make the best evidence-based choices, we also want to make sure as a field that clinicians are able to not only educate their patients and treat them with the best evidence-based medicine, but also to be able to go into community resources that are very specific to those patients' individual communities to find resources that are so important to make sure that there's a holistic approach to health, that folks are connected to other resources beyond medicine. All those other great things that patients really need to be connected to not only survive, but thrive. And so with that in mind, we want to make sure that as we talk and focus in so specifically on the relationship between these detailers or health educators and the clinician, that we're not forgetting about those relationships between the clinician and the patient, and that we're encouraging those clinicians to consider the patient experience and to understand that each patient has a different experience based on a plethora of factors, including, socioeconomics, race, gender, and their own communities and what's available there. And of course, we'll leave some time for you all to ask us the questions you want to know the answers to. All right. So let's get on over to the chat box, and we're going to ask you to respond with a word or a phrase. The first word or phrase that comes to mind when I toss you this word: HIV care and prevention. What's the first thing that comes to mind? Go ahead and type it in the chat box, and don't be shy, and don't feel that you need to cushion it. All right, HIV test, PrEP, medication. Great starts here. Thank you, Sean, Eduardo, and Paul. Our own Mike says underused. Yes, yes. Elias also says PrEP. What else? When you hear HIV care and prevention, priority. Yes, Keith, it is a priority. Community love. Thank you, Jess. Education from Nikki. Wonderful. What else do we have here? And panelists, feel free to engage as well. Compassion. Yes, much needed compassion. Excellent. I love the word community. I love the word priority. And also to recognize that the things that are priority, we're balancing right now between sort of some of the more urgent or seemingly more urgent priorities with regard to the pandemic, but that, we as a collective healthcare field really want to make sure that we're not losing sight of these other priorities and other public health crises and things that really need attention. Elias, sex. Yes, thank you. We're going to talk a bit more about some key messages for clinicians when there may be a sense of discomfort talking about sexual health. Bolo says evolving and advancing. What a great way, a hopeful way to wrap up this response. I'm going to ask you for a few more. All right. So the next one is quality improvement initiatives. What is the first response that pops into your mind? A word or a phrase? Data. Thank you, Paul, for kicking us off. What other words or phrases come to mind when you think about quality improvement? Evaluation. Thank you, Sean. Nikki says best practices. Yep. Elias shares surveys. Eduardo says networking. Jess, something we need to fight for. Oh, I really like that. I like that. Any others? Other participants and panelists have any responses to quality improvement? William says, always room for improvement. Or maybe you go by Chase, William. If that's the case, let me know. Impact. Thank you, Paris. Data collection. Chase, thank you. All right. Great. One more before we transition. Ideal healthcare delivery. What does it look like? Can you picture the ideal healthcare delivery, the setting, the type of care? What comes to mind? Pie in the sky. Comprehensive. Thank you. Accessible. Thanks, Winnie. Yes, access is key. Compassion. Yes, Eduardo, that's wonderful. Teamwork. One-stop shop. That would be great, Cindy. Mike. Patient-centered, evidence-based. Safe and effective. Tailored to client population. Thank you, Nikki. Proactive and intentional. Love that, Jose. Cultural competency. Yes. Racial equity. Yes. Thanks, Jess and Julie. All right, we'll let a couple more trickle in, but thank you so much for sharing your thoughts. And hopefully it doesn't feel too risky to maintain hope and to be able to illustrate what we'd like to see in healthcare. And thank you, Elias and Sean, for wrapping up with comprehensive and community-based and community-driven. All right, thanks for participating. I'm going to turn this over to Mike to talk about, to take us from what we want things to be, and he'll talk a little bit more about what we think medical care should look like, and then the reality, but we'll make sure to try to maintain that sense of hope. So thanks for kicking us off, participants and panelists, with some nice interactivity, and over to Mike.
Thank you, Bevan, and thank you everybody for your input in how clearly mission driven all of you are. So I should have put a little spoiler alert on my comment, because I said what some of the things I think an ideal medical care system should be. But I think we all would agree that it should be effective, it should be safe, it should really be as affordable as possible for the patient populations that we all work together to serve. Those are things we can all agree with, but we know that as a medical care system, as doctors, nurses, pharmacists, everyone in the system, we don't quite hit that target. We don't do things optimally. There are really beneficial treatments, therapies, tests that we don't use as often as we could. PrEP is a great example of that. We know that adverse events, drug and other complications, or even true errors are much more common than we'd like. And of course, especially this year, we see patients struggling to pay their medical bills. But that's true even before all the hardships that the pandemic created. And we see those pressures on the entire system. So we know that we're not delivering the optimal medical care that's as effective and as safe and as affordable as we would ideally like it to be. Now, part of the reason that that is so important is because we do have a lot to offer. It's easy to say we fall short in healthcare right now, but the difference, especially over the last few decades, is how much more we can do for our patients if we get it right. So we're talking today about HIV care, and that is perhaps the most dramatic example that we have. I'm of an age when I was doing the early stages of my medical training. The hospitals I was training at, we had acute HIV and AIDS wards and a team of interns and residents and medical students. And we would admit patients with acute complication of AIDS, and our teams would fill up every night with new patients. It was a whole ward. Now in the developed world, in most parts of the US, those patients are in an outpatient setting getting chronic treatment, for many of them having relatively limited day-to-day impact of their disease. It's a remarkable change. And if we can get this right, the idea that we could even move on and think about ending the HIV epidemic is truly unbelievable. If you'd said that to sort of 1995, me looking at some of our full wards, or even the people a few years before that. And those things are, it's important to realize as we think about the larger context that this is dramatically true for HIV, but is true in so many other areas. The skills and the impact that academic detailing can have is true across care for heart disease, gastrointestinal disease, psychiatric disease, so many other areas where we have effective treatments that weren't present in prior decades, but that we still don't get to all the patients who could benefit. So now let's start to think about what are some of the challenges. Why is it that as frontline clinicians, we don't quite get there in delivering the care we want? So as Jose mentioned in the introduction, I spend part of my time still as a practicing primary care physician. And it is helpful as we do this academic detailing work to recognize the day-to-day reality that we all face, that stress levels for frontline clinicians, primary care, and everybody else on the front lines are really high. And we have to think about what are some of the reasons for that.
So Mike, let's go ahead and ask folks what they think. Pop on over to the chat box and let us know on the daily, what do clinicians have to contend with? Anything and everything that comes to your mind that would make stress levels high, and you can put as many as you like. And those of you who are clinicians will know all too well what some of the challenges are. So think, What do all clinicians have to contend with? Maybe those who work in certain settings. So thanks, Anna, for kicking us off. Time as an issue. Yes, every clinician that we've spoken with, not a single one says, I got plenty of time. Sean, thank you. Having to deal with more than one patient. Yes, and when you pair that with being crunched for time, it's really difficult. Julie, limited resources. Yes. Julie, tell me a little bit more about what kinds of resources are limited, just so we can get a sense of what you're thinking about. Chase says clients not attending lab/OV appointments, language barriers. Yes, so important. Language and cultural barriers, right? So folks may have, a sense of, oh, we could get an interpreter, but the clinician themselves, if they do not speak that language, it may be difficult to get a sense of direct relationship building with that patient. Eduardo says in the pediatric setting, dealing with the parents, yes, especially with teenage patients, particularly around HIV prevention, I'm sure. Thanks, Julie, for expanding. Limited resources in terms of cultural relevancy. That's so interesting to get a sense of what you were thinking of. There's so many different types of resources we think about. So that's excellent and something we at NaRCAD have been thinking more about. Nikki says practice management, data entry, insurance issues, changing policies. Whew, and I see Mike nodding his head. Chase says stigma. Yes, that's something that folks often don't think about initially as the main challenge or one of the major challenges that clinicians have, but they certainly do. And it's none of us are free of stigma and our own stigma, and certainly, stigma towards certain patients who are dealing with specific conditions, that does exist. Jose says multiple platforms. Jose, tell me more about that. Danielle says lack of comfort talking about sexual health topics. Yes, we are going to hit on that. And Pedro says being overwhelmed. Yes, this is a lot. This is a lot. And, definitely things that I know Mike contends with as a general internist. And Elias shares one more. Disconnect with gender identity, sexual orientation. Yes, yes. Mike, can we get a little nugget from you about how you maintain hope after this waterfall of challenges? Like what makes you feel like you can show up every day and not be burnt out?
Yeah, it's a great point, because and I think the framing is important. It's a good one to pick up on, because the issues you raise are very realistic, and those are the downside. I think for so many of us who still do frontline clinical care, it is the reward of working with patients and making those personal connections that reinvigorates you. And especially, and it goes back to the slide we had just before this, when you can do something for your patient. I mean, sometimes there's a treatment you can't, a patient has a condition you can't fix, and you can be with them and support them, and that's important. And I don't mean to minimize that. But when you have that moment when you realize, I can offer my patient something. This is a person who's scared about their risk of HIV, and I can counsel them and I can offer them effective prevention, and they get it and they go away feeling like they're empowered. That's really powerful. I mean, that's why people go into helping professions in the first place. And when you can connect with that, that can give you the internal resilience to deal with all those other challenges that you mentioned, those administrative hurdles and others that are frustrating. But if you feel like the goal you're working towards is worthwhile and rewarding, then they're just speed bumps instead of mountains.
Awesome, Mike. Thanks so much. And what I love that one of the words that you use that I think really works well when we're thinking about what you and other clinicians hopefully strive to do for their patients, and what we as a field of health educators and detailers seek to do with clinicians, is that word counseling, right? That implies when you're pulling away the sort of tangible medication, screenings and things like that, that the human approach is so key. There's a reason we have clinicians as humans, not robots. They're not just doling out medications and looking just at that. There's the context of who is this person? And that's what we as a field try to consider when our educators go in to speak with clinicians. Every visit is different. All right. So one of the things that you all brought up is that that there's a lot to keep up with and not enough time. This will be very clear with this slide. We used to have an older stat here, but we found many more, and Jose was great at kicking us off with a stat about the past couple of years. In 2004, so we're talking more than 15 years ago, it was estimated that an epidemiologist would need 627 hours a month to review papers that were relevant for primary care. And now imagine that epidemiologist has no other life but to read these papers. He, she, or they still have to figure out what are the nuggets from these papers? How can they be applied to clinical care? And since 2004, the volume of articles that come out every day is just bananas. I mean, it's through the roof. So thinking about that, also realizing that not all of the evidence, if you did have 627 hours a month to devote, is of equal quality. So you not only have to try to find the nuggets, you have to make sure they're good nuggets. All of this creates just an impossible challenge for folks on the front lines. And that's where we maintain a sense of hope as detailers. So Mike, I'm going to pass it back to you to talk about how we can bridge that gap a bit.
Yeah, so if we try to think about what do we need, and I'm wearing my primary care clinician hat because as Jose's very generous introduction covered, I've trained in some of these methods, but nobody has the time to review all that data themselves. So if we're going to take all of that evidence and make it useful to clinicians, we need to find the data that is high quality, but that also is relevant to the clinical problems that a given clinician faces. It's got to be about what they actually see. And it has to be practical and easy to use. Frontline clinicians are smart, but they're busy. So it's got to be useful, and it's got to fit the setting that they practice in, not just the clinical areas, but are they in an outpatient, an inpatient, an emergency setting? It's got to be in a way that they can use it in their setting directly. And it really needs to touch on the actual decisions they face. It can't just be, let's give them the data in a sort of knowledge for knowledge sake kind of way. That's important conceptually, but we're thinking about how can we help our patients? What are the decisions our patients face that they're coming to us for help with? If we can put data into these kind of formats, then we can really help clinicians. And what we're driven by, what our purpose is the belief that academic detailing is an approach that can meet these needs and help clinicians use that evidence effectively and in a way that helps their patients. So the goal of academic detailing is really to get at that issue we've been talking about, where there's the best available evidence for what we ideally would be doing for our patients, and actual clinical practice, where we know that for a variety of reasons, we don't quite get there. We don't get the right test or medication to the right patient as often as we'd like. And if we can help to close that gap, then we're meeting our goals.
So how do we do it? Well, first, let's get a sense. You all have been so great at sharing your thoughts. Let's get a sense of a few more things, and then we'll tell you how this works. So when you hear the words pharmaceutical sales representatives, what is the first thing that comes to your mind? And you can be honest, as many who have done webinars with us have been. All right, thanks, Sean, for kicking us off. Big pharma. Chase says commissions. Yes. Elias says money. Yes, money. What else comes to mind when you hear the words pharmaceutical sales reps? Thanks, Nikki. Sales and profit. Winnie says conflict of interest. Couple more dollar signs from Pedro. What else do we have here? Maybe this is a good place to start. We'll let a couple more trickle in. Jose says, new yet often inaccessible products. Tell us why they're inaccessible, Jose, and you can either unmute or type it in the chat box. But I have a sense of where you're going. I just want to make sure I fully understand. Why inaccessible? Let's CJ Dante says insurance, which could be one of the reasons that products are inaccessible. Jose says people haven't always heard of them yet, and cost. Excellent, thanks. So awareness of a particular treatment and then access financially. Keith says used to partner better with the community. All right, good stuff here. Thanks, guys. All right, one or two more here. When you think of researchers and academic faculty, what do you think of? And don't be wary that there are researchers on the call. What do you think of when you hear the word researcher? You think of an academic. And panelists, you're welcome to participate. Non-people of color. Yes, I think that might be the first time we've heard this in response to number 2. Thank you, Jay Dante. And I hope I'm saying if it's either Jay or Dante, I'll let me know. What else? Pharmaceutical sales rep, information to access medications and patient assistance. That's all good. That's a positive thing. Thank you, Elias. Thank you. What else? So we're hearing that researchers and academic faculty, if they're not people of color, then they're white, right? So that's a majority. That's a position of privilege. And certainly there have been more and more pushes to get people of color and have representation within research and academia. Anyone else have some thoughts about researchers or academic faculty? Jose says long-term resources. Yes, yep, research can certainly be a long-term resource. Anyone else? Thank you, Elias. University, health department, government. Okay, helpful. Thank you so much. So let's talk a little bit about looking at these, drug reps, sales reps, which we're calling like the industry, and then academia. So along with the great things you all came up with, we know that pharma reps are terrific communicators, at least if they're doing well. So we saw the word commission, we saw money quite a few times. Their incentive is to promote a particular product, and as a result, they will be able to bring in money for the company that they represent. But while they're doing that, we can't deny that they're excellent in communicating and figuring out what they need to say in order to make that sale. Academia, on the other hand, is that trusted clinical information, but without offending Mike, it's often very lecture-based. Academics are not particularly, there's no focus on training for them to communicate in that jazzy, impactful way that's very much based on a dialogue. So if we can steal what we think are the best traits and qualities from both sides of this, that's where academic detailing comes in. And we'll tell you a little bit more about what it looks like. Before I tee it back to Mike, I see a comment from Sean that really backs up what was said about non-people of color being in academia, that Black and Latinx folks make up 3% of academic faculty in the US. So what we're also looking at is just, another way that we can improve as a field in terms of academia that will also impact academic detailing. So Mike, tell us what academic detailing looks like.
Sure, and thank you again, everybody, for the really great and on point comments. So what does this actually look like now that we've kind of set up the concepts for you? So academic detailing is direct educational outreach. They're ideally one-to-one visits, sometimes one to a couple, depending on the sort of dynamics in an office, where you go to the frontline clinician's own office. You're seeing them in the place where they're thinking about their patients, making decisions. You can really focus. And while it is educational outreach, at its core, it is a supportive service for better patient care. It's about the clinician and how as a detailer, we can serve them to be there for their patients and provide better care, not for them to serve us by listening to a lecture. There we go. But when you're having these one-on-one visits, you're able to provide the information interactively, and that lets an academic detailer understand a clinician's knowledge, their attitudes, their behavior. And for a topic as we think about things like HIV prevention and the prescribing of PrEP, it's a perfect example where different clinicians may not know about it, or they may know about it but have attitudes that are not helping them recognize which patients they should be discussing PrEP with. You can imagine where being engaged with the practitioner, staying in a dialogue and continuing to assess their needs can maximize your effectiveness in this interactive format. And when you do that, instead of the way a sort of a lecture, you know, a traditional educational format is, where you have a couple of bullet points you decided on a few weeks ago that are your take homes, you actually end an academic detailing visit with specific practice change recommendations that are customized to that clinician, that grow out of the discussion you had. Ideally, the most successful programs have featured return visits over time, so that you can strengthen that relationship you're developing, that the clinician understands, they trust that you're there to promote better care. They recognize the usefulness of having that kind of high quality information. So that's what academic detailing looks like in broad strokes when it's happening out there on the front lines.
Thanks, Mike. So those of you who maybe haven't seen a video or a little trying to wrap your heads around, okay, we saw an image here, right? There's people pointing at things. Let's talk about what it actually looks like. So a good academic detailer will walk into a one-to-one session, which is typically on average around 20 minutes in length. If you can get more, you're lucky. If you get less, it's extra hard. But folks who we train in our trainings certainly are up to the challenge, and we help them prepare for all kinds of situations because you never know what you're going to get. So you walk in and introduce yourself, making sure as a detailer that it's very clear who you are and very clear who you aren't, that you're not a pharmaceutical sales representative, that you're there as part of a free service, either representing a health organization or a public health department. You can even share who your funding comes from. So to say, I'm here from the X public health department, and we have a Project Pride grant from the CDC to speak with you and other clinicians in your area about what it's been like for you to provide treatment and prevention options for your patients with HIV or who are at risk of contracting new HIV infection. You'll then, after introducing yourself, ask open-ended questions. So not yes or no questions, because you can get shut down pretty quickly that way. If you were to say a yes or no question such as, do you need help taking care of your patients who are at high risk for HIV? And they say, nope, then you've got nowhere to go. But if you were to say, Dr. Fisher, talk to me about the typical patient who comes in who might be at high risk for HIV. How do you assess that they are at risk? And that gets the clinician talking about his, her, or their experiences, their knowledge, their beliefs, any potential stigma, and what they may find challenging, and also the ways in which they're practicing. And you, as a detailer who is armed with the best, most up-to-date evidence, can then assess on the spot, all right, which direction should I go in here? Maybe Dr. Fisher says, I always refer my patients who have HIV to an infectious disease specialist. So if I'm the detailer, I'm thinking, that's pretty old school. And I might share with Dr. Fisher, you know, through this grant, we're communicating to primary care clinicians such as yourself that it's really critical that HIV treatment is something that is discussed in primary care versus handed off. Or If Dr. Fisher says, I don't have any patients who seem like they're at high risk, I can tell when they're at high risk, then you need to explore a bit more. It sounds like maybe they have a little bit of a stigma going on. And so you may explore that by asking another open-ended question to figure out what's going on. So you may say, Dr. Fisher, talk to me about how you have a sense of who's at high risk. Do you do anything systematic, or is it more of an intuition? And so these types of questions allow you to explore what's going on in the mind of that clinician and how they practice. Once you figure out where the knowledge gaps are, or where you may be able to be helpful by presenting specific tools, resources, and support, that's when you're able to go to this third, in the purple here, the third block. You will deliver a key message that is relevant to what that clinician may need. And so you may say, in one of the instances that I shared, you know, Dr. Fisher, it sounds like a systematic sexual health history assessment is something that could really help you figure out exactly who's at highest risk. And that way you're using the same approach. It's evidence-based. Can I show you a sexual health history questionnaire that has been proven to be effective in determining who is at high risk? Once you're sharing a key message, you're then going to prepare to handle objections from that clinician. And one thing we always say is, if you're a great academic detailer, you will get objections. If Dr. Fisher nods politely to me as a detailer and says, yeah, that sounds great, just leave the questionnaire with me and I'll talk to you sometime, he's probably not going to use it. But if he says, well, how do you know this is effective? Or I'm not comfortable asking this question here, then you're able to talk about, similarly to motivational interviewing, which many of you, I'm sure, are very familiar with, you're able to assess what that resistance might be to behavior change and roll with that. Once you feel that you have delivered a key message that you think that clinician is open to adopting, you'll summarize what was discussed and you'll close the visit asking for a commitment. This is where it's very similar to pharmaceutical sales. So instead of saying, Dr. Fisher, thanks for meeting with me, I'm going to leave this questionnaire with you, bye-bye. You could say, Dr. Fisher, we had a great discussion about the challenges that you face in your day-to-day practice. And it sounds like you're really interested in trying a few new approaches. How would you feel about using this sexual health history questionnaire with the next 3 patients you see this week? And maybe we can hop on the phone or share an email back and forth about how it went. Could you try that? And Dr. Fisher may say, sure, I'd love to try that out. He may say, gee, I'm really not sure. Can I just try it with 1 and see how it feels? And you can take that as a win too. As we, as detailers, try to, nudge clinicians towards the best evidence-based medicine and practicing that medicine, we want to make sure that we see the smaller wins as successes. So now you have a sense of the fact that academic detailing is interactive, that it's not your typical quality improvement initiative, and that it's not a lecture. So I'm going to turn it back to Mike to talk about what the essence of AD is not, the things that folks may say is AD, but it really isn't by our standards. So Mike, talk to us about this.
Yeah, and this is important because there is really that interactive component that Bevan and I have talked about over the past few minutes that is central. But, we never patented or trademarked, or I don't even know which it would be, which tells you how businessy we are, but the academic detailing, so people can say whatever they want. And it's worth knowing, if you're setting up a program or hearing about it, that if you go into a doctor or a nurse practitioner or PA's, any office, and just give them a traditional lecture, but you're only giving it to 1 or 2 people, but it's still didactic. You're talking at them you're not finding out about their practice and assessing their needs, then it's just a small lecture. It's not really academic detailing. It doesn't have that interactivity. On the flip side, really good reviews of the best evidence with practical tips and all kinds of things that you put down on paper or on a PDF and send through regular mail or email, they can be useful for reference, but on their own, they're not going to change behavior. That's not academic detailing, no matter how detailed and accurate those memos or brochures may be. It's also important to know there's been a number of people who've glommed on to academic detailing as, especially insurers, as being a way to cut costs. So it's totally reasonable if I'm wearing my primary care doctor hat for someone to come to me and say, hey, you shouldn't prescribe your patient expensive medicines if there's a cheap alternative. Well, that's right. That's good care, taking good care of my patients to not make them waste their money. But if it's just about don't do anything that costs money, just about you have to comply with this formulary, it's not really with the principles of academic detailing because it's not focused on the best evidence for the care of your patients. It's also not just an attempt to undo industry marketing. Some people like to refer to academic detailing as counter detailing. So the idea is that the industry folks come in and say, hey, use our brand new drug. And then the academic detailer will come in and say, actually, there's a lot of good alternatives. Now, sometimes that will be the dynamic, but sometimes not. For example, here in naloxone, we do a lot of work with public health departments trying to address the opioid crisis. That's sometimes expensive, but is very effective and should be prescribed. PrEP often can be expensive, especially over the last bunch of years that Truvada has been the only PrEP available. But of course, academic detailers focused on PrEP would be encouraging the use of Truvada, just like the industry reps would. Now, of course, it's about to get very interesting now that there are multiple options for PrEP and potentially going to be more. And that's why that independence of the academic detailer is so important.
Thanks, Mike. Anna is letting me know that we are somewhat on time, but that we may need to kick it up a little bit. So with no further ado, I am going to talk briefly about the community lens that I know many of you are very interested in and dedicated to in your day-to-day work. So academic detailing is not just looking at the relationship between the detailer and the clinician. It's also considering what the patient is receiving in terms of care. And so even though our focus is on that, building that relationship from detailer to clinician, it's really interesting to think about the ways that it can complement other elements in the community. So working with other stakeholders, working with patient advocates, so thinking about all of your PrEP navigators and other community initiatives. So with with HIV initiatives, we know that there is sometimes a crossover with folks who have substance use disorder and may use injection drugs. And also with the opioid crisis, we're looking at other types of harm reduction with naloxone. So I think between looking at community initiatives, such as community education and looking at harm reduction, that's where academic detailing can really dovetail beautifully. And so, Mike, I know you've hit on some of these pieces. I'd love us to actually move right to the key messages if we can. So Mike's going to talk to you about how key messages are action-based and just give you a moment to read these and also talk about the first two just to get a sense.
Absolutely. It's been really exciting to think about how academic detailing can be part of the HIV prevention effort. And you see there on the slide why it's such a natural fit. As primary care doctors, we have more to learn. There are behaviors we need to adopt. but it's nuanced, and these key messages embody that. I'm not, as Bevan said, going to go through all of them, but what you'll see about key messages, a point I'd like you to come away from this slide with, is that they are action-based. A key message isn't sort of a fact that you're asking a clinician to memorize. It's an action that they can take to help their patients. Some of them can be pretty basic, like the first one here, that's taking a thorough sexual history on all your patients at least once a year. That's really good sort of bread and butter, good primary care, but we know it doesn't happen as often as we'd like. And the second one you see as an example is test for STIs. And then you see the specifics there. But again, you look at these key messages, their actions: take, test, talk, follow up. You're really trying to give a clinician the practical steps that the evidence leads them to. And that's so important if we want the HIV prevention we know is possible to be realized in real world practice.
Thanks, Mike. And so I'm going to ask all of you to pop on over to the chat box another time and say what you think when looking at these key messages. What would make a primary care clinician reluctant to try these? Any one of them. You know, we have what Mike shared, doing testing, conversing about PrEP, testing for other STIs, and following up. All right, Jay Dante kicks us off. Pride. Okay, talk to us a little bit more about that. If you can expand on that. Are you talking about pride of the clinician to not talk about this content, or looking incompetent? Yes, that could be an issue. What else, folks, participants and panelists? Why do you think a clinician would be unwilling to try any of these key messages? And Mike, maybe you can type something in as well to let us know what you think in terms of working with other clinicians. Why do you think clinicians would find this too hard to do? Nikki, thanks so much. Biases per biomedical HIV prevention. Chase says lack of knowledge or confidence. Mike says perception that antiretrovirals can only be prescribed by specialists. Paris says lack of time between patients. Anna says, I'm going to say time again. So great. We all have a sense of how the challenges we talked about before can be expanded to look at why these key messages would be hard to sell. And Sean, thanks for sharing about looking through a Southern lens, that some clinicians still don't believe the science behind PrEP. And Elias wraps us up with funding sources, lack of resources, costs for PrEP. And Eduardo says, again, the pediatric setting makes it uncomfortable to talk about these things, even with teenage patients, and providing condoms sounds unusual at a children's hospital. Yeah, so a lot of this is you know, potentially a lack of comfort here. And William, or excuse me, Chase brings up STI testing supply shortages due to COVID. So that's challenging. So you guys hit on a lot of these: the stigma, the belief that it's subspecialty. We also have potential changes in medications that are available that Mike talked about a moment ago. And Elias shares yet another: they easily refer them to the AIDS service organization instead of testing in the office. So that's another case of putting prevention and testing into primary care. So to wrap up, we know that good academic detailing programs consider identifying what's the gap in the care. So looking at high-risk patients don't get tested enough. High-risk patients are not prescribed PrEP often enough. So you define your intervention goals based on those gaps in care. You want to consider what's the change you want clinicians to make, or in many cases, what are the multiple changes you'd like them to make. You then recruit and train your education specialists, your detailers, to make sure they're ready to go into these in-person or virtual visits now that we've had to pivot as a field, to try to make those changes happen in partnership with the clinician, delivering those visits, and then building capacity and sustainability of your program, which often goes hand in hand with evaluating successes and areas for growth of your program. All right, one more of these. What are some key community groups that work to improve public health. So think about your community, think about what are the community groups that are so critical besides, looking at healthcare. What other groups are working to improve public health? I know in our community, looking at the city of Boston, there's a lot of public education. There are other organizations that support it. So Sean says local churches with food banks. Yes. Peer education, workforce development groups, community advisory boards. Yes. And I'll note that these things are other important and critical ways for patients to be healthy and have access to resources. Reproductive justice groups. Yes, absolutely. Many finger snaps happening. And then one more, who do primary care clinicians interact with most often? So in the day-to-day, what are primary care clinicians like, Mike? Who do they talk to the most often? And thank you, Elias. Community health workers, promotoras, yes. And then Mike, maybe you can type in, who do you interact with most often besides patients? Who would you say you spend your time connecting with? Chase, thank you. Nurses, support staff. Excellent. Pharmaceutical reps. Yes. Yes, indeed. Some of them do. Some of them have a policy against it. Our own office staff and colleagues, not in the community, not the community, right? So let's talk about engaging the community. And thank you, Sean. They're partners when they get to decompress. Yes, decompressing is key. All right, so breaking silos and encouraging communication. We're going to talk about this rather quickly so that we can make sure there's time for some questions. Academic detailing programs really want to raise visibility of AD across services and supports and identify community champions to increase that awareness and build those partnerships. When we look at AD as part of a larger whole, we want to consider complementary initiatives. So community pharmacy, emergency departments, law enforcement training, public awareness campaigns, as you brought up. We heard about advisory boards, family services, behavioral health, housing, transportation. All of these things are so key. And so let's give an example here. This is going beyond communication techniques and clinical content and considering, again, how are detailers trained on up-to-date community supports such as the ones you came up with in the chat box. So Mike's going to talk a little bit about community resources for the elderly.
Yeah, so I think that these, so much of academic detailing, when you're thinking about how it fits into the context of an intervention, is planning carefully for what we're going to bring to the clinicians, and then thinking about what else is needed, because healthcare is a complex intervention that's in a big system where people are living their lives. And so we need to think about what else is there. Over the years, I've worked on a lot of programs that are focused on the elderly. And so often there, for example, if you're doing a detailing intervention with clinicians trying to reduce the risk of falls in the elderly, or address cognitive issues like early onset dementia or elder abuse, so many things that we need support with as clinicians. We need clinical information, but we also need to know about, for example, elderly day programs that can provide support, area agencies on aging. These aren't necessarily the high-tech, sexy interventions, but they can make all the difference by giving extra tools so that your messages for the clinicians are much more effective. And so whatever your context, whatever element of HIV prevention you're focusing on, if you can take advantage of that knowledge of the community, hopefully diversity of backgrounds among you and your colleagues, you can really maximize your effectiveness.
Absolutely. And so with that in mind, we want to talk about the ways in which your individual work in the community and work with your partners really, makes it either able for you to connect patients to resources and advocate for them, or where there are gaps, and also to answer any questions that you have about academic detailing and how it can be impactful around HIV prevention and treatment. So thanks so much for listening. I want to make sure that Jose and Bolo, if they want to add anything, that they can. But please do ask any questions in the chat box. Jose, what are some of your thoughts to kick us off? I know you've heard about AD before and we presented before, but in terms of thinking about application of AD within a larger community context that can really support patients, what are some of your reflections? If I can put you on the spot.
Absolutely. Thank you, Bevan and Mike and Anna, for walking us through that presentation and overview. One of the things that's exciting for me, and I know that we maybe switched for time, was actually the journey mapping exercise that
I
y'all
can pull that up.
about.
Yeah, I can
I
pull
wonder if
that
you
up.
feel comfortable sharing some of that, because I think that's where some of the fun actually comes
Yes.
out with academic detailing, right? That data
Yes.
is a story and a journey that we're walking through together.
Absolutely. So when we're looking through that patient lens, we actually need to put ourselves in the shoes of the patient. And I'm so sorry that we rushed through this. I think we thought we would have a bit more time than we took. So want to talk to you about this really cool thing called journey mapping. So when we consider what patients need to be healthy, we really want to consider all of the different supports that you guys thought about and that we think about often at NaRCAD. So it's not just that they need primary care, it's that they need other things when they're going through the process of getting resources and care. So journey mapping, and we'll make sure you all have access to this process because we don't want to speed through it too much. So do not fear, we'll make sure you get the slides. Journey mapping is visualizing what is the patient process. What does he, she, or they go through to accomplish a particular goal? So here are the steps. The first thing you want to do when you're considering a patient is not make it just any patient. What is their, if you want to choose a particular mapping process, how do they identify in terms of their orientation or their gender? What is their racial background or their ethnicity? What is their, where are they socioeconomically in terms of across the spectrum of, income and looking from poverty to affluence. And then you want to imagine the journey that the person would take from the beginning through to getting their prescription filled for PrEP in this instance. So what's the goal? Is it to get them on antiretrovirals? Is it to get them to walk out with a prescription of PrEP in their hand? What does it look like? So here we have examples of, they're leaving their home and they're walking in the door. They're interacting with reception. Maybe they get their vitals checked by a PA or a nurse. They chat about PrEP with their primary care clinician. Where do they go after that? Do they go to their community pharmacy? And so the goal with journey mapping is you draw it out, and we'll show you a really cool example of it right after this. And doing it with a team is critical because you may have someone say, oh, wait, but what if they have to go to a specific pharmacy based on their insurance or income level? Or what if they're at a community health center and it's very backed up and they're not able to get their prescription that day? What does it look like? And then you present your ideas with a larger group of colleagues. So here's a really great example. This is sort of the PrEP journey. If you see on the bottom right, and you have a little stick figure of a person who's walking through all of the green checklists to try to get to where he, she, or they needs to go. And you'll see it's got a couple different offshoots of what could happen along the way. And then within those purple clouds, the group who did this wrote, what is that patient feeling through each step? So at the beginning, you'll see they feel confident. And then as they go through, they may be sad if they test positive. They may be distracted. They may be anxious and relieved, frustrated, happy. Regaining their insurance makes them excited. Having a certain type of partner, things like that. So this is what the journey map looks like. Jose, is that what you wanted us to share?
Yes, thank you so much. And maybe we
Sure.
can leave that image on the screen. And so the folks can kind of see that journey map. I know that we're also almost at time, but I think that's a good place to like have our folks a good image for to have our folks looking at as we start transitioning. But I did see that we had one person mention that they had some comments they wanted to
Yeah,
share.
Nikki, we'd love to hear what you have to say. Maybe can we unmute Nikki? Is that possible, or
I
can we
believe,
just do chat box?
let me see, Nikki, do you feel comfortable? You should be able to unmute. Or
Okay, super. Can you hear me now?
yeah.
Yes.
I sound like a commercial. Can you hear me now? So first of all, I want to say very unsolicited that still to this day, with my almost 40-year career in HIV, that my training by NaRCAD 2 years ago in San Francisco,
Yes.
still to this day remains one of the most impactful and productive trainings I've ever had. That is a completely unsolicited comment. really, really
I'll
quick,
pay you
really quick.
later. I'll pay you
So,
later.
one thing I wanted to just impart to all who's listening. So we in Broward took the bit and run with it, and we detailed more than 1,000 physicians. We recruited about 380 to be involved in HIV biomedical prevention. But some of the key lessons we learned was we had toolkits all set up that we left with our physicians, but key lessons are, since physicians are science-focused and data-driven people, we led with a spreadsheet on the local overview of HIV infections in the area, and that could be also modified for like people over 50. We're in South Florida, we have a large retired population. People are forgetting that over 50 is still a big population. We're also second, unfortunately, in the country behind Miami-Dade County in the rate of our new HIV infections. So lead with data, because that instantly gets their attention. And it can't really be refuted. I mean, it's not a sales pitch. It's just what it is. It's data, epi data. So then link best practices, annual sexual health history takings. So critically important. What physician does not want to integrate more best practices into their course of business? Virtually none. So that's something concrete. And then also, I think if once COVID's over and we start back in the field to do this, we're going to have a link, website link, that when you leave your card, they have a link to go to. They can download documents. And so you have something that they can lock onto if they are interested. The other thing was also doing lunch and learns with staff,
Yes.
because staff really run practices, especially the senior staff, right? And plus they have husbands and boyfriends and sisters and daughters. And so they're going to go home and say, wow, we learned about this really awesome stuff. So you're almost maximizing your impact so it's not just the people in the white coats, so to speak, but it's the entire practice. And we were lucky that we worked with Gilead here with Truvada to get lunch and learns where they would bring in food. So we kind of used that to support our effort. And then also on the management side, have spreadsheets really well laid out, have protocols. If someone says, no, I don't want to talk to you about this ever again, you mark them on the sheet, make sure you don't do that. People who are somewhat interested, you come back like in 2 months, have it very organized on the back end, because as you reach more and more, as you do more and more physicians, it can get complex to manage all that. But I just wanted to say that's what we learned from our experience in the field. And thank you for all the great stuff that you guys continue to do.
Thank you, Nikki. And Nikki, you are a celebrity on our website, as you all can see. Actually, Nikki was in my group, and Deb Monahan on the right there Deb and I helped train Nikki, so it's so lovely to hear your voice. And this is Nikki in action, doing a final role play. And wow, Nikki, you rocked it. You rocked it.
Thank
You
you
were
so much.
such a natural. So I'm not surprised to hear that you have so many amazing resources, and we'd love to pick your brain sometime and maybe even feature you on a best practices
thank you.
blog.
And,
So
and my
you so much.
colleague, Michael Alonso, who's now up and
Yes.
coming in Gilead,
Oh,
he's
wow.
also every sentiment that I echoed just now, he would vouch for. So he's a
Thank
true
you.
believer. And I will say, just as a really super quick side note, part of the Ending the HIV Epidemic Initiative does include workforce development. So I loved your comment really early on about weaving academic detailing in with peer education and other groups in the community. I think that's kind of like maybe even the next evolutionary level. And I think it could be done nationally. I would hope it would. Because stigma, getting through the force shield of stigma and mistrust is best done by a peer. And I think there's some way we could weave that together in some kind of framework. I don't know, but anyway, thank you for letting me say everything I said.
Thank you,
Thank
Nikki. And
you.
thank you for modeling the spirit of collaboration and personhood that really is at the heart of academic detailing, and for ending us on a positive note. So thank you again, Dr. Fisher, Bevan, and Anna. Dr. Fisher has shared his contact info. Nikki, looking forward to seeing whatever happens once y'all reconnect with NaRCAD, and to continuing this conversation with y'all. We have a upcoming session momentarily. Apologies for running late. We're going to close out with just a quick poll around our interpretation services. We've had our fabulous interpreters keeping up with us so far, and want to just acknowledge their work. Thank you, Susan and Abraham. And thank you all for joining in today. If you all have any other questions, please reach out to NaRCAD. They'll be hosting many more sessions that y'all should be checking out, and please follow their website.
Thank you so much. Yes, visit us at narcad.org anytime. We'd love to get on a phone call with any and all of you. Take care and have a great rest of your day. And thank you so much, LACOA, for having us on this special presentation.
Yes, thank you.
Thank you. Take care. And thanks, Nikki.
More to
Take
come.
care. Hope to see you soon.
Yes, bye.
Bye-bye.
All right, farewell, y'all. And our next session begins at noon. So go get some water and get a snack, and we'll see you soon.